All right. So thank you for coming to Ending the HIV and HCV Epidemics in Indian Country, an Urban Perspective. So I'm Andrew Collett. I'm from the National Council of Urban Indian Health. And NCUIH, as we call ourselves, is a national membership nonprofit organization devoted to the support and development of quality, accessible, and culturally competent healthcare services for American Indians and Alaska Natives living in urban settings. One of the ways we do this is through training and technical assistance, and this is our TARC team, Training and Technical Assistance Research Center here at NCUIH. I'm Andrew Collett. I'm joined today by Sabu Kuyumjian and Mark Clark and Kimberly Fowler. And these are the urban Indian organizations who are our members. And before I get started, I wanted to thank the Indian Health Service, in particular Brig Riley, the HIV and HCV National Program Epidemiologist, and Rick Haberkay, the National HIV/AIDS and HCV Program Director. They'll be taking over shortly, and before I pass it over, I just wanted to remind people that in order to ask a question during the presentation, we'll monitor the chat box in the bottom right. So you can just type any questions or answers into the chat box. We'll make sure to monitor that and bring anything on. But without any further ado, I just want to hand over to Brig Riley with an update on hepatitis C virus in Indian Country.
Hi there. Is my audio okay? Just a quick confirm.
Yeah, you sound great on mine.
Okay, so I'm going to do a quick overview on Hep C, some of the basics and the activities that we're doing in collaboration with IHS, and I'm going to try to leave plenty of time for questions because different people will need different things out of this, as far as where do you get the drugs or how do you treat.
Hello, welcome back.
And I'll go ahead and get started. So real quickly, there's some basic risk factors here for Hep C transmission. The ones in color are the ones that are the most predominant. And you'll see, of course, in the top left, injection drug use, which is really driving the current nationwide epidemic. In the past, some of our older patients were exposed historically through blood products or medical exposures. And we'll talk about some of these in more detail. So as far as epidemiology, primarily bloodborne disease, and we have about half of our persons, this is not Indian country, there's a lot of CDC national data points, they're considered unaware of their infection. So the best estimate is about half the people who have Hep C are aware of it. Because of its long duration of often being asymptomatic and no obvious risk factors or clinical presentations, then a lot of times it's diagnosed very late in its course of disease, and that's one of the interventions we're trying to address here is early diagnosis. As far as new infections, we talked about injection drug use briefly, but we also have intranasal drug use, non-professional tattoos, and a lot of other routes of transmission. And we have about 20% of our patients, that's a ballpark figure, there's no clear risk exposure. So the patient, it's either been so long ago or was considered inconsequential at the time. They truly cannot recall how they might have been exposed to Hep C. So this became an unfortunate milestone a few years ago. If you look at the line, this is deaths from nationally notifiable infectious diseases. Hep C became greater than all the other disease conditions combined as far as number of deaths it caused. So basically more than TB and HIV and some of the other reportable diseases. All of them added up do not meet the amount of deaths that hepatitis C is causing each year. Happily, this curve is hopefully starting to bend down for reasons I'll talk about in the treatment section. Here's a very basic overview of the course of disease. It isn't always typical like this. It can often go much quicker if there's an underlying health condition. diabetes, HIV, and other situations. But this is the textbook presentation that after exposure, about 75 to 85% of the people will have chronic hepatitis. So as you notice, that's not 100%. Some people will self-clear the virus. They'll get sustained virological response, which is our fancy name for a cure. They will defeat the infection on their own. But for most people, they will progress to chronic hepatitis. As I mentioned before, no signs or symptoms until 20, 25 years later. We're looking at cirrhosis, and then a few years later, greatly increased annual risk of hepatocellular carcinoma, end-stage liver disease, and death. So there's chronic hepatitis is actually a lot higher. It's about 80%. And whoops, didn't mean to blow right through that. And then you get a lot of patients progressing to cirrhosis and then Hep C related mortality. As I mentioned before, here's the graphic from CDC. About half the people are unaware of that status. I think in some Indian country facilities by now we're doing better than this. We have quite some good screening coverage and some new screening guidance that came out. So one thing to know, it's a common disease. In relative terms, we're seeing a lot more hepatitis C than HIV. In most communities, anywhere to 10 times to 100 times more persons will have Hep C, depending on where we are regionally. It is the leading cause of liver cancer and liver transplants nationwide, again, not just in IHS. And the estimate is about 3.5 million persons. Highest mortality rate is in American Indians, Alaska Natives, over double the national mortality rate. So there's a big disparity here. This could be a combination of late diagnosis, lack of access to care, underlying conditions, but it's very fixable. And I think that's really the biggest point of this presentation is if we can find people early and treat them, it's never been easier, and it's going to have a huge impact in terms of reducing mortality and reducing this disparity or eliminating it. This is, again, a national slide. It's not unique to IHS. This is sometimes called the tsunami slide. I realize the font is kind of small, but if you look in the legend, DCC is decompensated cirrhosis, HCC is hepatocellular carcinoma. So these are adverse outcomes from hepatitis C chronic infection. You can see transplants, deaths, all of this. If you look at the, I don't know if my arrow is visible on the screen, but if you look at the left, we're at the bottom at the x-axis, we're at about 2020. And so we're just starting to go up the face of this huge wave. So the worst is yet to come as far as the numbers of persons who are going to have bad outcomes from Hep C if we don't ramp up treatment aggressively. And this is CDC, again, estimate. We have this really big bandwidth of persons born from 1945 to 1965. There's different overlapping ideas of why this generation was so, this birth cohort was so overly affected. But for our purposes, we know that they are, and this is a really important age group to check. Now, if we were to continue this curve out past 1980 and such, we would start to see another big spike. So this, instead of being a one spike epidemic curve, it would start to look like kind of cat's ears or a barbell or something, because we're getting our younger generation, a lot of new infections in younger patients now. So with that previous data that you saw of persons born 1945 to 1965, this became a national recommendation in 2012. Just screen everybody. And screening, again, it doesn't matter if they have no apparent risk factors or anything, just give them the test. And part of the reason for screening is because now we can do a lot more. Before, you couldn't do much with a Hep C positive result, or your options were very limited, but now it's kind of gone from the rotary phone to the iPhone as far as what we can do. So back then we had limited treatment options. It took a long time, often half a year it could have been. You had tons of side effects to deal with. You had a lot of contraindications. So if the patient, their BMI was too high or their depression was not within a certain limits, according to certain scales, you couldn't even start treatment. High default rate. Because of the side effects, a lot of people dropped out. They decided they'd have enough. And even after you've gone through all of this, the success rate was poor. You maybe had a coin flip as far as whether it works. So about a 50% cure rate. Really difficult. So unfortunately, this is still the idea that exists in a lot of, I think, community members' minds, both with misconceptions on transmission and misconceptions on treatment. It can make stigma higher, and it can make linkage to care more challenging. Okay, now we've got a lot of treatment options, and in fact, it's almost coming back down to really only 2 regimens. We kind of blossom there to like 5 or 6 different ones depending on the genotype, but now the treatment options are pretty much pan-genotypic, north of 95% cure rates, short duration, so usually 8 weeks, and it's 1 to 3 pills a day, oral only. So we're getting almost everyone who's starting is getting cured. You may have noticed this simplicity. This takes things away from where it used to be. You had to go see a hepatologist and you had to do all this intense monitoring. If you look at the simplicity of what treatment is now and how effective and the lives it can save, you can see why primary care settings and urban clinics could be a really important focal point for both diagnosis and treatment and linkage to care. We have had a problem with drugs. They're famously extremely expensive, but that has really changed as well. So if that is if that is perceived as a barrier where you are, we can talk about it in the Q&A. But the short answer is the price have come way down. More third-party payers are on board. The barriers and the requirements for Hep C treatment, even in state Medicaid, is coming down each year. So I think coming in January of next year, even some of our most difficult states are going to be covering Hep C without much interference. So here's what we're trying to prevent. Again, end-stage disease is really, it's really a horrible progression of disease. And I think a lot of these conditions that we're seeing here, often Hep C is not even diagnosed. It's still a hidden killer, and I think the death rates would be even higher. But again, it's often doesn't make it to the death certificate. So what do we get? Here is why we're doing this, right? SVR12, you remember that sustained virological response. So that's 12 weeks after you've completed treatment and you come back in, and if you are negative at that point, you are considered cured. So here are some of the stats. I'm not going to read them out loud, but huge declines in adverse effects and mortality with the cure. It is probably the single biggest health intervention that I know as far as a biomedical option for an infectious disease in my lifetime. So it's really been a stunning turnaround, where before you would just say, well, we'll have to monitor your liver and hope you're not one of the unlucky ones. Now we can get aggressive, treat it early, and cure people. So here's the other bottleneck we're dealing with in Indian country, right? Specialist providers. There's not many of them, and there are a ton of patients who are who need treatment. Remember, we're not just talking about new infections. We're talking about people who have been exposed over the last 30 to 40 years, and we need to get them triaged, identified, and treated as soon as possible. And then once we deal with that for the next 2 to 3 years, hopefully, your new infections are going to be a relative trickle, so you're not going to be scrambling to keep up. And this has been the experience of the VA. They've treated almost 200,000 patients, and now they are actively looking for new patients because they've gone through so many of their infected cohort that they've really got a success story, and they're almost out of patients. Here's a typical cascade. Happily, this bar graph is about 7 years old, 6 years old, but it illustrates where we lose patients at each step of the way, right? So we've got to, of all of our patients, we've got to diagnose them. Then we've got to link them to treatment. They've got to get started on treatment and complete it and achieve an SVR or a cure. So what we want to do is really have our right side column achieved SVR at about 90%. And so that means lifting up all of these bars. And again, this is where testing our patients and being sure they can navigate care or get care in their community is going to have a huge impact on this this current loss of patients as they work their way down the different steps towards a cure. So mainly what we're doing in IHS is increasing screening and diagnosis and treatment. Nothing fancy there. It's about doing it. So we have an electronic reminder in our RPMS system. That's our government system. If you're in an urban site that uses a private sector EHR, we are in touch with a lot of 638 sites that use private vendor reminders, so we can put you in touch, be it Epic or eClinicalWorks or something else. We can help you with a reminder. We also have a policy template that's on the IHS website that we can send to you. And this is a good testing and treatment template that you can then customize for local use so that your medical team can be on the same page. And once you decide what level of services you want to provide or what level you need to refer out, this can be a very helpful tool to get your facility on the same page. So where are we? If you look back in 2012 when the recommendation first came out, we had screened 11% of our baby boomers. So this is a cumulative measure. So each year it just keeps filling up like a glass till we get to 100%. You don't have to retest them. It's a once only test unless they have ongoing risk behavior. We are now up to 65% as far as the latest. So we've screened a majority, which is really good. Our challenges remain getting people who only access emergency care and urgent clinics, and they don't access primary care and have a regular provider, but we're working on that. Urbans, again, this is more challenging. I think, urbans there's a very wide variety of urban facilities, ones that are just, that don't have a provider, or ones that maybe are more sophisticated and could treat in-house. But the bottom line is, at least our reported screening rates are a lot lower in urban facilities right now. There's some asterisks by that data. So your mileage may vary as far as locally, and we can help you with your local data. But there's a huge opportunity to raise that rate and do early diagnosis. Here's an example from Chicago. The Chicago urban site they installed a couple reminders, put in a policy and practice template, and they are among now our national leaders, one of the highest rates of coverage for both HIV and Hep C screening. So it's really been a success story. And once they put this in motion, it really only took them a year or two to cycle through and go from kind of middle of the pack to far beyond anybody else. We had a special general memo go out to IHS because of the high mortality rate in American Indian Alaska Natives, because of the benefits of early diagnosis and treatment, and because the screening itself is such a non-invasive and reliable test that we've decided now to go to universal screening. So everyone 18 and over should get a hepatitis C test. Again, that is largely data-driven and due to cost-effectiveness data that we're going to prevent a lot of transplants and cancer and save a lot of lives. But also because we're seeing a lot of our new patients are under 40 years old, not just the baby boomers, but younger folks. So we're trying to overcome our special limitations with telehealth and teleconsultations. So if you're out in an urban spot without any easy support, or out in a rural site, we are linking people to care. We're also doing clinical training. So we'll bring you to, if you're not comfortable yet treating Hep C, we'll give you an immersion day so you are familiar with it and you get to know your specialist, kind of a one-day boot camp. And we talk about drug procurement strategies so you don't have to deal with that whole process on your own. It's almost like doing taxes for the first time. It's hard the first time, but once you get to know the system, somebody on the medical team usually gets really good at this. A lot of regional telehealth now as far as ECHO. So we have multiple, we have national and regional options. You can join any one that fits your schedule. Here's what it looks like, a lot of video screens, kind of old Hollywood Square style. And here's the Hep C one. It's gotten a lot bigger. This one I think was in 2012. But now, if you look at the map, we're all over the place. And in fact, this has a lot of empty spots that would be populated in the Northwest and California, because this was just the University of New Mexico based one at the time. So you would multiply these dots by a lot. And Cherokee Nation, of course, would have 7 or 8 of their own pins on this because they've started their own. Well, you know, I think we talk about all the technical stuff, but I think from clinical satisfaction, there's very few conditions now that we cure. We generally manage chronic disease and you're on pills for a lifetime. But here we get to say, look, we're done here. We cured it. And I think the gratitude of the community where you're providing this service, they know it's hard to provide, the gratitude of the patient. And, you know, one of our leading providers said, I have gotten more hugs working in Hep C for 18 months than I have in 20 years in infectious disease. So it's really a win-win for provider and patient on this one. And so we have some concrete services we can give to urbans that I can talk about in the Q&A, about getting you started, everything from screening to figuring out how many patients you have historically and who's the most urgent for care, how to link them to care, so that you can get them to treatment locally or you can treat in-house. Because I would say probably about at least 36 sites in IHS are now treating at the primary care level. And I believe that is my last slide. I went a little bit longer than I thought, so I want to leave a lot of time for the other presentation and for a Q&A. But I think that's it. Thank you. So I can take questions now, or we can push on to the next presentation, whatever our hosts want to do.
We can move on to Rick unless there are any questions popping up in the corner, but I don't see any. Are you on the line, Rick?
Yes, I'm here. Hi, Andrew.
Hi. Thanks for joining. So I'll just start off you.
Great. Are you going to give control to me, or should I just ask you to switch slides?
I can move them for you.
Okay, sounds good. Well, I really appreciate that presentation by Brig. I think that's such good news, the fact that we can offer people a cure for something that people thought was more of a terminal disease and definitely something that was very chronic and life-changing. I can't offer you the same thing with this HIV presentation. There is no cure for HIV, and there is no vaccine for HIV, although that's been in the works. I just got back from a biomedical conference talking about the testing that's going on right now, some of the research happening around a vaccine. But, you know, the good news is we're not waiting anymore for any kind of miracle. We're not waiting anymore for new science. We're not waiting anymore for new techniques. People now living with HIV can live a long, productive life into their 70s, even their 80s, with the kind of therapies we have now. And people who are at risk for HIV, but currently not HIV positive, can take a one-pill medication, 1 pill a day, every day, to completely prevent HIV infection. So there is some incredible good news. I wanted to talk a little, you can go to the next slide, please. While we go through this presentation today, and it's just to give you a little bit of an overview of what's happening in HIV in Indian country, and I want to talk about ending the HIV epidemic, a plan for America. And as much as I can, I'll focus on urbans when I can. But I want you to pay a little close attention to some of the key topics I'll talk about today. By the end of this presentation, I hope you will be able to state the main goal of ending the HIV epidemic in America, list the 4 key strategies of the plan to end HIV, and then describe what we call treatment as prevention. Next slide. Let's go over quickly some of the current statistics for Indian country. American Indians and Alaska Natives face very significant health disparities in rates of sexually transmitted infections, including HIV. And from 2005 until 2014, the CDC reported a 63% increase in rates of HIV among gay and bisexual Native men alone. And the overall rate for Natives increased by about 19% in the same period. That's alarming. A lot of the communities in the country have actually seen reductions in new cases of HIV, but sadly we're seeing increases in Indian country. In that same report, the CDC also stated that the undiagnosed rate for natives living with HIV hovers around 18%, while the national undiagnosed rate is about 13%. And it's significant. That undiagnosed rate is significant because if someone does not know that they're living with HIV, they don't know that they're transmitting HIV to others. And we know that about 80% of new infections with HIV come from those people who do not know that they're living with HIV. So screening and testing is of utmost importance. We really need to do a better job of getting people in for screening and testing. And we are doing a much better job in a lot of our Indian Health Service and tribal and urban clinics, but we need to work harder. Next slide, please.
Yeah, and just a note, Rick, we're getting a couple people saying they're having a little bit of a hard time hearing. So if you can speak up at all, I know that would be appreciated.
Okay. Is that better?
It's better on my end.
I'm sorry, I had a headset on, but I switched to the handset. So I'm on a landline. I'm hoping it's a little better. I've got the volume turned up as high as I can go. So hopefully if it's better. I apologize, folks, if you couldn't hear something, but maybe in the Q&A we can have me repeat a few things. People are saying it's a little better now. Good deal.
Yeah.
Alrighty. So similar to some of the other demographics, the most significant burden for HIV is among Native men who have sex with men. And they account for around 80% of all of the HIV cases among American Indians. That's probably not out of line with what's happening in the rest of the populations in the United States. But just so you know, American Indians who identify as men who have sex with men are carrying the largest burden of new cases of HIV infection. But women, Native women, show a rate of HIV diagnosis that is 3 times the rate of white women. Very significant. Also, data looking at racial and ethnic differences in HIV/AIDS survival rates showed that Natives had the lowest survival rate after an AIDS diagnosis compared to any other race. And according to 2013 data from the CDC, about 53% of all Natives diagnosed with HIV were receiving continuous HIV care, compared to about 58% for whites. So whites are doing better with keeping in care, but we're not doing a horrible job. Well, 53% of our people are in care. We need to do a much better job. I mean, that needs to be up around 90%. So once someone is diagnosed with HIV, we need to get them into care as soon as possible. We need to keep them in care because if someone stays on their antiretroviral therapy, they get to a state called undetectable viral load. And that means that they are incapable of transmitting the virus. And that's where this great new term comes in. Undetectable equals untransmittable. If you are living with HIV, but you get your viral load to an undetectable level, that means you are incapable of transmitting the virus to others. So just imagine what that means for people's ability to live a normal life. They can have relations with people without the fear of transmitting the virus to others. So it's an incredible feat of science that we can't negate. While we don't have a cure, we don't have a way to inoculate people against HIV, we know that we can get them to a state where they're incapable of transmitting the virus. Next slide, please. I wanted to let you know that the ending the HIV epidemic is an effort that the Indian Health Service has been intimately involved with. When this was announced in the February 2019 State of the Union address, we were very excited about the fact that Indian Health Service was one of the key players along with some of the other HHS folks. So the President said that he was going to plan to give millions of dollars, including $25 million to the Indian Health Service to achieve the goal of ending the HIV epidemic in America within 10 years. So when you think about ending the HIV epidemic, what we really mean are eliminating new cases of HIV. It's going to take years and years and years to eliminate even if we stop today, new infections stop today, we'd still have people living with HIV. We'd still have people who might be diagnosed with AIDS. So just remember the fact that we're talking about eliminating new cases of HIV. Next slide, please. We know that HIV has cost America too much for way too long. More than 700,000 Americans have lost their lives due to HIV since 1981. And more than 1 million Americans are still living with HIV today. And there are many more at risk for HIV infection. And I said before that new diagnoses have significantly declined from their peak. There are still 40,000 Americans being newly diagnosed each year. And that's what HHS looked at when they made this plan up last year. The directors of the top agencies of Health and Human Services said, why are there still 40,000 new cases of HIV every year? We have the ability to eliminate this. We need to try harder. We need to bring that down to 0. And that's what our plan is. We want to reduce the number of new cases of HIV by 75% 5 years and by 90% in 10 years. We spend about $20 billion annually on HIV care. And we know that there is a risk of a resurgence in new infections arising. We think the messages have sort of fallen to the wayside about condom use. We think people are not hearing enough about the ability to get on HIV medications that get them to an undetectable viral load. And we know that people aren't hearing the message about pre-exposure prophylaxis. So I wish I had been able to put a question on the board here that said, how many people have heard of PrEP, pre-exposure prophylaxis? I'm just curious to know how many people might have heard of it. Don't worry about answering that, but maybe you could add, oh, I see Andrew or Mark or someone's putting it up on the screen right now. So yes or no, have you heard of PrEP? And as we go through the next couple of slides, we'll see what the answer is there. So we'll go to the next slide if you could. There's the goal I talked about, reducing by 75% the numbers of new infections in 5 years and at least 90% over the next 10 years. So we know that that would eliminate or prevent about 250,000 total new HIV infections if we're able to reach this benchmark. Today, next slide, please. Today, we do have the tools to end the HIV epidemic. The data says that most new infections occur in a very limited number of counties and among very specific populations. And you might have heard of phase 1 of the epidemic, the plan to end the epidemic, and its targeted counties. The U.S. has about 3,007 counties, give or take a dozen. In just 48 of those counties, plus the District of Columbia and Puerto Rico, we see more than 50% of all cases of HIV. So out of 3,000 counties, 48 of them bear the burden of 50% of the epidemic. So this program is really focusing on those parts of the country. In its first couple of years, we're really going to focus on those areas where the infection rate is the highest, and among populations like African-American men who have sex with men. But I, as IHS program director, really want to concentrate on our American Indian populations, and that includes our urban centers. If you look on that map from hiv.gov, you'll see the dots around the country, and I might have that map coming up here in a little while. Maybe the next slide. We'll see where, here's the agencies who are working on the plan. CDC, HRSA, IHS, NIH, the Office of the Assistant Secretary for Health, and SAMHSA. Next slide. Here, there we go. Here's the dots. You can see these are the 48 jurisdictions in the country that have the highest rates of HIV, new cases of HIV, and this is where we're really going to concentrate. And you might find yourself in one of those dots. And Indian country certainly is part of those dots in our urban Indian health centers around the country. So rest assured that we see you. We're focusing on you nationally as well as within the Indian Health Service, and we're going to do our best to make sure that we get the types of resources that you need. A lot of that will come from training providers, training clinics to maybe consider implementing new policies on screening and treatment. But the biggest thing I think we want to do is talk about PrEP. So I see good numbers on this call. Nearly 90% of you have heard of PrEP. Incredible. I'm glad. So pre-exposure prophylaxis is a regimen of 2 oral antiretroviral drugs in a single pill. Right now there's one major drug on the market called Truvada. It's made up of 2 different medicines combined into one pill. It's incredibly effective, up to 90% or higher effective in preventing HIV infection. And it's designed for people who are living without HIV, but who are at risk for HIV. And that includes just about anybody who's not in the monogamous relationship, but it certainly includes those who engage in sex with men who have sex with men, those who might use sex as a means to survive, those who maybe trade sex for housing or food or safety, those people who have had 1 or more STIs in the last year. And it includes those people who just walk into a clinic and say, hey, I think PrEP is for me. Those are the people who should be getting PrEP. And I just put PrEP on our core formulary. So if you're qualified and you walk into an Indian Health Service operated clinic, you are able to get PrEP free of charge. And a really great new thing happened just this week. Health and Human Services got into a deal with one of the drug manufacturers who are offering 200,000 doses of PrEP for free over the next 10 years.
For housing and safety.
Here's somebody talking. Maybe we have to put a message on the Facebook line. So anyway, anyone who does not have prescription drug coverage qualifies for this new PrEP
they're
donation.
just like very like, there's no like.
These are not getting the message. I'll keep going. So anyway, if you go to hiv.gov, you'll see this new program called Ready, Set, PrEP. There's a short application process to qualify. You just have to prove that you are a resident of one of the 50 states and you don't have prescription drug coverage. And that includes people who are eligible and maybe receive their care from Indian Health Service, tribal programs, or so totally for free. It does not cover the labs. Our tribal, urban, and IHS offices will still have to cover the quarterly lab tests that are required for STI screening, and we have to make sure that people's kidneys are functioning well, and that we remind them as often as possible that you must continue to use condoms. PrEP only prevents HIV. It doesn't prevent syphilis or gonorrhea, chlamydia. So we really still need to drive home the message of condoms. Next slide, please. The main pillars of the plan. We have to diagnose, and I talked about how important it was to make sure that we diagnose all people with HIV as early as possible. And we have to
The leader has muted your line. To unmute your line, press *6.
Can people still hear me?
The leader has unmuted your line.
Okay.
Sorry about that. I accidentally muted the lines.
Okay, I think I'm back. The second pillar is to treat people with HIV as rapidly and effectively as possible in order to reach that sustained viral suppression. The next pillar is prevent. We have to prevent new HIV transmissions. And that's the biggest one there is the inclusion of PrEP. We need to get about 50 to 60% of all the people for whom PrEP is indicated, we need to get them on PrEP. We have a long ways to go, especially in Indian country. I don't have the actual stats. I could get them for you, but right now I think we probably would have a few hundred people on PrEP, where we need to have a couple of thousand people from Indian Health Service, tribal, and urban clinics on PrEP. And we need to respond quickly to potential HIV outbreaks. And one of the things that Indian Health Service has been lucky to do through a grant from the Minority HIV/AIDS Fund, we were able this year to fund 9 of the tribal epicenters around the country to help us be able to figure out where new outbreaks of HIV might be occurring in Indian country, and to help us get the message out about HIV care, treatment, and prevention. Next slide, please. Next slide. I think I got ahead of myself earlier. We'll just jump to the next slide here. Another great opportunity IHS had with funding from the Minority HIV/AIDS Fund was to fund the Cherokee Nation pilot project. And they're going to sort of be a microcosm, and we're going to look at them with a microscope, not to judge them, not to poke at them, not to ridicule them, but to examine how successful a program can be in Indian country that focuses on ending the HIV epidemic. Cherokee Nation cured more than 800 people of hepatitis C, so we know that they have the capabilities and the experience and the technology as well as the staff and the political will to put a program like this in place. So we're going to use them as a learning lab and see what it is that they need to do, what they do, how they get people in for screening, for care, and how they get them on PrEP. And we'll copy what they do and expand it throughout Indian country. Next slide, please. I mentioned the tribal epicenters, and they received about $2.4 million divided up between 9 of the epicenters. There are 12 of them in the country, but only 9 applied. So we'll see what kinds of outcomes we can get from the tribal epicenters around things like preparing tribes to look at HIV, preparing tribes to help us gather data which meets their needs, not the needs of IHS, not the needs of HHS. What is the data that meets the local level needs, and how do we help them measure their successes? That's predominantly what the tribal epicenters are funded to do. Next slide, please. And then the biggest part of this is listening to our communities. When the proposed $25 million was announced for Indian Health Service, by the way, we haven't gotten the funds yet, and the budget for 2020 has not been approved, not been finalized. So I can't tell you 100% that we're getting the $25 million that's proposed, but what IHS has promised to do is to listen to our communities, and that means our tribal and urban communities. So we funded the National Indian Health Board and the National Council of Urban Indian Health to conduct a series of tribal consultation and urban confer sessions around the country. And NCUIH will be sponsoring its first listening session next week, and you probably all have seen some of those announcements. I think it's next Tuesday, the 10th of December. So we're making sure that we hear the voices of the community and community leaders before we embark on
the word I used.
anti-HIV epidemic in the country. We really want to make sure that we hear from our communities. Next slide, please.
Never? It's all Whopper job.
Finally, we don't really look at my back before I talk anymore. Nobody needs to see that. You can see my contact information. I'm just teasing. But one final thing I wanted to say is we're also funded the Albuquerque Area Indian Health Board to promote the National Native HIV Network. And they're forming a group that will meet face-to-face over the next year.
Center sideways, not right, messed up.
Made up of representatives of those who are doing the sort of boots on the ground work around Indian country, and they'll report to me so I can see what the assets are. Maybe I can see what some of the unmet needs are. What I can see, and I can report back to IHS leadership information on programs that are needed on the ground to make a real difference and help us meet the goals of the HIV country. And I'll finish up there, and we can move on to the Q&A.
Thanks so much, Rick. So if anyone has any questions for the Q&A, microphones should be open now. So you can click on the little phone button on the top if you've joined via computer. If you called in, as you can tell, the call-in lines are open. And just feel free to chime in. We'll also monitor the participant chat in the bottom right. And while we wait for some questions to come in, I also wanted to mention the listening session that the National Council of Urban Indian Health will be hosting on the 10th. So if you are from an urban Indian health program, NCUIH will be providing a forum and a platform for urban Indian health programs across the United States to express their community circumstances, needs, perspectives, and interests before the Indian Health Service officials at the national level. but yeah, I'll just open the lines up from them, and also our contact information as well. Looks like we have a couple people typing.
Andrew, maybe while people are typing to ask questions, I can also mention something about another big program we're working on is to reduce the stigma that we know is sort of endemic around the country, around the world when it comes to HIV. There's a stigma around infection of HIV, people living with HIV. There's a stigma on the way transmission routes are because of sex and drug use. But, we see a lot of stigma around men who have sex with men, around transgender women, around people who might be using sex as a tool to survive. We see a lot of stigma around people asking for PrEP. But sometimes it's kind of like what happened back in the 60s and 70s when women first started getting access to birth control pill. It was assumed that they wanted it because it sort of legitimized their desire to be have multiple sex partners, or there's lots of stigma out there. So IHS is working really hard to destigmatize HIV and destigmatize LGBTQ and Two-Spirit folks and destigmatize access to PrEP. So if you go to IHS.gov and search LGBTQ, you'll find some great resources for providers, for communities, for people who are identifying as Two-Spirit or lesbian, gay, bisexual, transgender. And you'll find some tools also that, if your provider, help you look at how to implement an HIV screening guidelines in your clinics, how to implement PrEP, and how to access our Project ECHO. And maybe Brig can explain a little bit more about what Project ECHO is. But we can answer this question that's coming up. I think this one's for Brig, so we'll get to that Project ECHO in a second. I think this question's for you, Brig, online.
Yeah, so I'm just going to read off the first question because I think it's a little bit related to what you were talking about regarding stigma. So the first question we have is, what suggestions or recommendations do you have for Native youth and young adults on these topics? And any suggestions for how to broach the topic for parents or supportive adults with their youth?
I would recommend that people go to this website operated by the Northwest Portland Area Indian Health Board called We Are Native, WERNATIVE, wearenative.org. And you'll find some great resources there for parents and children. There's a really nice source called Ask Auntie, where people write in questions, and one of our Native women from the Northwest responds to the questions. And people ask all kinds of questions. What do I do? My parent found out that I'm gay, or I'm scared to tell my mom that I'm, doing X, Y, or Z. So Ask Auntie will give some really good scientifically sound questions. There's some incredible videos that people can watch of some Native folks who talk about their lives and their experiences. We talk about how people are sort of thriving and surviving once they come out as LGBT, or what it's like to recover from alcohol and substance use. So really good stuff on there for parents. And then in that same, Northwest Portland also provides a source for educators and provides a lot of good curriculum that's been tried and tested and proven to be effective in Native communities. And that's called Healthy Native Youth. So We Are Native and Healthy Native Youth. I recommend those to you.
Yeah, so Sabu actually just put We Are Native in the chat box, and that's specifically for the Ask Auntie tool. I'm going to switch gears a little and read the comment for Brig. Nick Walsh says, great presentation. A comment: at the most recent liver meeting in Boston, the American Liver Association issued jointly a statement with the European, Asian, and Latin American societies calling for a decentralization of care from specialists for non-complex cases. So even specialists are now saying that we need to decentralize to primary care to reach HCV elimination. That's also their position at WHO.
Great. This is Brig, and I
Sure.
just, I have to agree.
Comment.
Oh, I was going to say I completely agree. Thanks for the comment, Dr. Walsh. And as you already know, we're making getting tons of support from our pharmacy layer. They've really turned out to be real leaders to support our providers and doing almost all the case management, especially with our non-complex patients, of course. But both in Cherokee Nation and nationwide, pharmacists are being a real key link in the chain. That's all.
Thanks. And I also wanted to read off Ryan Rhodes' comment from Wisconsin. He says, in Wisconsin, our tribal HIV coordinators have voiced that their elders and council members are not supporting HIV prevention and care programming and not seeing it as a priority. So what has been successful in changing that?
This is Rick. I think we've seen this in other parts of the country before, not just in tribal communities, but in lots of places around the country. And I think what changes that is just perseverance. People who take the time to go and maybe do some face-to-face meetings with some of their elders. They work on the idea that, hey, this is a real issue in our community. It affects me. It affects you. I think it takes time to change people's attitudes, beliefs, but it can happen. But I think a lot of it is people just spending that time one-on-one, going to tribal council meetings, getting on the agenda, maybe writing articles with the tribal newspapers, maybe doing radio shows, maybe talking to people who are on the talking to relatives of people who are on tribal councils and kind of going in a backdoor way. But I think people have changed their opinions just from one occurrence of someone really giving them a heart-to-heart, face-to-face talk about how this really does affect all of us, including our tribal folks. So I don't have a miracle cure. I don't have any way to change people's minds except knowing that it happens slowly. But it really oftentimes is just that personal one-on-one meeting with someone in a calm, peaceful sort of atmosphere. But maybe there's ways that we can come and do presentations to those communities that are most reluctant to incorporate HIV programs. I'm happy to do that.
Thank you. I think the questions are kind of tapering down. I'm not sure if anyone has anything else. I'll give it a minute. While I wait for that as well, I'd just like to go ahead.
Excuse me, just one second. Brig, can you mention the tribal echo? I mean the echo programs real quick. Give a plug for the website.
Yeah, I think a great resource for Hep C, HIV, and new emerging ones. We talk about the importance of telehealth to support our persons in any facility on any subject and getting that knowledge to you when you need it. It's IndianCountryEcho.org. ECHO is the acronym for our telehealth. So IndianCountryEcho, ECHO.org. And there you can see about in-person trainings. You can email someone for more support, or you can just get on there and observe some of the telehealth clinics. You don't have to present. You can just sit there and absorb some of the case studies and eventually present a patient if that's what you need to do.
Thank you, Brig. In addition to the clinical echoes that Brig mentioned, we're going to be starting up a gender care echo probably sometime next spring or summer. We're hearing a lot of talk around how do people provide better care for those people who are identifying as LGBTQ or Two-Spirit, those people who are transgender, and our clinicians are looking for information how they provide that care in a more effective manner. So we'll be starting up a gender care echo.
If you're transgender or Two-Spirit, that's the presenter.
Sorry, was that a question about transgender and Two-Spirit individuals? A little hard time hearing. Sorry about that, Rick.
I'm sorry. Did you not hear my comment, or that you're asking someone? Because I heard a voice in the background too. I wasn't sure who.
Yeah, I heard a question come through, but I couldn't hear it.
Oh, okay.
Sorry.
We also have an LGBTQ and Two-Spirit work group at IHS. So if anyone's interested, you can get a hold of me and see if you'd like to be on that group for LGBTQ and Two-Spirit folks. And it's open to anyone who's interested in American Indian, Alaska Native care for LGBTQ and Two-Spirit folks.
All right. Thank you. We've actually pasted some links to what you've been talking about regarding Project ECHO and the LGBT Two-Spirit work group. And unless there are any further questions, I'm just going to remind you all to fill out the evaluation when this meeting ends. You should be presented with a link when the webinar closes. But other than that, I just want to thank you both, Brig and Rick, again for presenting this information today. I think we all found it really informative, and thank you so much.
Oh, you're very welcome. Thanks for having us.
All right, thank you. And yeah, just everyone stay on the line and fill out